The first question was write the names of the muscles attached at the perineal body. Okay, so that was part A. And remember, although I have given it in a more detailed fashion, okay, but for a 2 mark question, you just have to mention this. Okay, so what and draw the diagram. Remember, anatomy and certain places you are expected to do the to have images and diagrams attached, which really helps the examiner when checking. So bulbospongiosus, the transverse perineal muscles, the compressor urethrae, the external urethral sphincter, and parts of the levator ani, especially the puborectalis muscle. If you see this diagram here, this is the perineal body, this is the vaginal introitus, this is the anal canal behind, and the attachments here are the transverse perineae here, the bulbospongiosus here, and parts of the levator ani. These are parts of the levator ani, specifically the puborectalis. So also some fibers from the external urethral sphincter do come here, and some fascia is also attached here. So but these are the main muscle attachments. Okay, this is the first part of the question. The second part of the question was course of the pudendal nerve. Again, something which you need, which is not a very easy question unless you've done anatomy in detail. But since it's come, let's discuss this. The pudendal nerve, remember, arises from the sacral plexus, the ventral rami of S2, 3, 4. And remember, the course is divided into 3 parts. It traverses through the pelvis, then the perineum, and then divides into 3 main branches. So the question was the course, the branches, and the supply. Again, if you can support with a diagram, nothing better. But so this is the diagram. The pudendal nerve enters through the greater sciatic foramen near to the sacrospinous ligament. And this is the pelvic part. Then this is the perineal part where it goes through the Alcock's canal or the pudendal canal. And then it divides into the 3 main branches. The 3 main branches are the inferior rectal nerve, the perineal nerve, and the dorsal nerve of the clitoris. So these are the 3 nerves: inferior rectal, perineal nerve, and the dorsal nerve of the clitoris. This is the branches. What is the importance of the pudendal nerve is when we give, as when you're doing an instrumental delivery, forceps or vacuum, very commonly we give a pudendal nerve block. This is at the level of the ischial spine. Okay, so this is where you give the level of the pudendal block, right? And the last part of the question was describe the steps of repair of a 3C tear. Now, this is also a repeat question. This has been asked many times in the past. This is something which which is like a repeat, very commonly asked. Almost every paper you will get a question on describe the steps of repair. This has been discussed earlier. You'll find it there. Okay, so this is just to complete the answer. Again, you don't have to write all this. The DNB paper, remember, is very objective. Why I've written more detail than what is required when you see the answers we've written is to keep helping you revise. Okay, so the RCOG classification of OASs, we know that tears can be 3A, 3B, 3C, and 4, right? And they've asked 3C. 3C means both the external anal sphincter and internal anal sphincter are torn. Preparation requires the type of anesthesia, the position of the patient, maintaining asepsis, antibiotic prophylaxis. So whenever you write a question and they've asked you a procedure, make sure it's a complete answer, not just go to the steps. Always try and frame your answer. That gives a lot of positive impact on the examiner who's checking your paper. Okay. Then you have to identify, importantly in 3C, or you have to identify the internal anal, the mucosa first of all, then the internal anal sphincter, then the external anal sphincter. So if this is not a this is not a 4 degree, but if there it's a 4 degree, you have to identify the rectal mucosa and suture this with interrupted sutures. But here we're talking about 3C. So 3C will start from here, identify the internal anal sphincter, which is a paler sort of layer compared to the external anal sphincter. Repair the IAS, there are 2 ways, either an end-to-end anastomosis so sorry, that is for the external anal sphincter, my bad. Internal anal sphincter is an end-to-end anastomosis, either by interrupted or mattress sutures. The external anal sphincter is repaired by 2 ways, either an end-to-end anastomosis like this, or we do an overlap technique like this. So either end to end or overlap. And this is again suture. We use 2-0 absorbable suture. Here in the internal anal sphincter, we and this mucosa, we prefer a thinner suture, that is 3-0. Then, like any other perineal tear, the muscle, the mucosa, and always do a rectal examination to make sure no suture has gone through the rectal mucosa. This is in the event of a third degree perineal tear. Post-op care, very important: antibiotics, broad spectrum, stool softeners, analgesic, physiotherapy, follow up at 6 to 12 weeks. Advise the patient to have abstinence, not to have constipation, and assess the continence at 6 to 12 weeks, right? And of course, for further future planning of deliveries should be explained to her. So that is the first question. The second question was the ESHRE consensus on the classification of female genital tract anomalies. Now, this is a new question. It has not come before. And the second part was, how will you differentiate between arcuate, septate, and bicorporeal or bicornuate uterus on a 3D ultrasound? Okay, describe with the help of diagrams. Now, first of all, the ESHRE or the ESG call. So we have two types of classification systems now. The newest classification system for Mullerian anomalies, one is the ESHRE, the other one is the ASRM, Mullerian anomaly classification tool. So both of them you should know. Both are important, right? Here the ESHRE one has been asked. So in ESHRE, uh, these are recent classifications. What ESHRE says is that the basic structure is that they have divided uterine anomalies separately, cervical anomalies separately, vaginal anomalies separately. Okay, and each patient is assigned a composite code, because it's been found that there are many complex anomalies which coexist. So it's not only a simple septate uterus. It might be a septate uterus with a septate cervix with a transverse vaginal septum. So you have to put everything together, the three parts: uterus, cervix, and vagina. So uterine anomalies are labeled as U0 to U6, cervical C0 to C4, vaginal V0 to V4. So 6 types of uterine anomalies, 4 cervical, 4 vaginal. In the uterine anomalies, U0 is normal. Okay, that means no uterine anomaly. So if there's no uterine, no cervical, no vaginal, it will come as 0. One is a dysmorphic uterus. Dysmorphic means like a T-shaped uterus, okay, or a small uterus, an infantile uterus. U2 is septate, U3 is bicornuate, U4 is hemiuterus, means like a unicornuate, one developed uterus with a contralateral rudimentary horn. U5 is aplastic uterus, like a absent or even a rudimentary, like in MRKH syndrome. U6 is unclassified. Anything else which doesn't fit here comes under U6. So you have again U0 to U6. Then cervical anomalies, we have C0 to C4. C0 is normal. C1 is a septate cervix. C2 is double cervix. C3 is cervix is absent on one side in a hemiuterus. And C4 is no cervix. So this is the cervical anomalies. Then you have similarly vaginal anomalies. V0 is normal vagina. V1 is longitudinal, non-obstructing vaginal septum. V2 is longitudinal obstructive, like in Ovira syndrome. You have an obstructed hemivagina. Then transverse vaginal septum is V3 and V4 is absent vagina. So an example, this is just for you to understand. You have U3, C2, V1. Okay, so this is complete bicorporeal with double cervix. You would forget the B. The B is further subclassification with longitudinal vaginal septum. So that is how you should tell this is the ESHRE classification. Now, just to complete the answer, what are the key? So this is just a summary table. Then this is an advantage of the ESHRE system. It is comprehensive, objective, reproducible, clinically relevant, it is descriptive. However, sometimes it does not address the functional aspects. It is overdiagnosis may happen. So some limitations also I've mentioned, although this was not asked in the question. And as I said, don't worry, all this will be uploaded by tomorrow on the app. Okay, now this is the diagram. You can write simply. You can draw the different types of view. You can draw a septate uterus. You can draw bicornuate, uh, double uterus, a hemiuterus with or without a rudimentary horn. So you can do all that, and then you can sort of sub-classify your answer. I mean, help with the images. The second part of the question was, how will you differentiate between an arcuate uterus, a septate uterus, and a bicornuate uterus on a 3D ultrasound, on a bicorporeal uterus on a 3D scan? Describe with the help of appropriate diagrams. Now, remember, 3D scan is the gold standard for differentiation of these three anomalies, and it's quite. I'll just make put a blank slide and tell you how it helps. So if you, how is an arcuate uterus? An arcuate uterus is like a heart-shaped uterus. There is slight indentation at the fundus. Otherwise, these are the osteas. So what we do is we always draw a line between the ostia. This is called the interosteal line, and a line through the fundus. Okay. So this distance we basically measure on the 3D scan. Similarly, this would be a bicornuate uterus. This is how a bicornuate uterus is. The ostia are here. So again, you will draw a line between the interosteal line and this fundus. And then you have a septate uterus. A septate uterus has more of a broad fundus, okay? And then it has the septate like this. So the interosteal line is going to be here, and the fundus is going to be here. So this distance. Now, if you can notice, the distance between the interosteal line and the fundus is going to be least in a bicornuate uterus, because the bicornuate uterus has an indentation. So we see this distance, the distance between the interosteal line and the fundus. Okay, this is one of the things we see, and you can show this by drawing a diagram. The distance, if it's more than 5 ml, 5 mm, sorry, it is likely to be a bicornuate or even an arcuate uterus. But sorry, I said it oppositely. If it's more than 5, if it's less than 5 ml, it's likely to be a bicornuate or an arcuate uterus. If it's more than 5 mm, it's likely to be a septate uterus. Okay, there are a few other things we see. We see the intercornual angle. That is, if it is this angle here. If it is acute or obtuse, right? That is one angle we see. And we see a few other things. So the intercornual angle, if it's more than 105 degree, it is likely to be an arcuate uterus. If it's less than 75 degrees, it's likely to be a septate uterus. More than 105, again, a bicorporeal uterus. We also see the external fundal contouring. We see the internal cavity contouring, and this is what I said, the interosteal line to the fundus distance. Okay, and we see the intercornual angle. So three things we mainly see. Okay, and then if the measurements I've mentioned here, what I've explained to you basically, with the diagram you need to show. So the diagram is also here, and this helps differentiate between different types of uteruses. Okay, now the next question was something which is very easy, keeps coming: supports of uterus, POPQ classification, etiology of genitourinary prolapse, something which you should not miss out on scoring at all. Supports of the uterus, you can classify them as muscular. Okay, so basically you have to describe the pelvic diaphragm, the ligaments, uterosacral cardinal ligaments, then the pelvic fascia, then the peritoneal falls are the false supports. So these are not really supports, but just to complete the list mentioned. And then the vaginal supports. But always don't forget to mention the D Lancey's levels of supports. This is what the examiner is going to be looking for, the D Lancey levels. So level 1 is the uterosacral and cardinal ligaments. This is level 1 support. You can just draw level 1, level 2, level 3. You don't have to draw a detailed diagram. Okay, just a diagram like this would be enough. So level 1 is the uterosacral cardinal, level 2 is the pubocervical and rectovaginal fascia, and level 3 is the perineal body. So these are the levels of vaginal support, and this is something which you should not miss out in mentioning supports of the uterus. POPQ classification, repeatedly asked in the exam. Two things which are repeatedly asked: POPQ and labor care guide. Somehow in every exam this has come, so it's important to know these two. Okay, so POPQ classification, we have key points. You have to mention that it is, there are 6 defined points, there are 3 measurements, and you grade the prolapse from stage 0 to 4. Okay, then you have to mention the staging. You should also draw this diagram, at least, if not this detailed diagram, at least this grid has to be drawn: AA, BAC, GH, perineal body, TVL, AP, BPD. So this is very, very important. And the staging in the end has to be shown. Again, if you can't draw a detailed diagram, it's okay. But mention what is stage 0, stage 1, stage 2, stage 3, and stage 4. Okay, so POPQ, draw a lot of images and your job is done. Etiology of prolapse, again, quite easy. Divide this as acquired and congenital. In acquired prolapse, most of the time there is the cause could be an injury during delivery. There could be um, so vaginal delivery with consequent injury to supporting structures, the single most important acquired predisposing factor. So all these things are points related to the injury, what all can happen during injury. Mentioning injury is enough. Then menopause, second most important point you should remember is menopause. So one is injury, child injury during childbirth. Second is menopause, that there you can add factors like higher parity, okay, vaginal deliveries, hysterectomies, okay, when doing a hysterectomy without supporting the vaginal vault, this is for vault prolapse. Other contributing factors are the age, genetic predisposition, ethnicity, lifestyle is very important. So mention about chronic constipation, COPD, obesity, heavy lifting, women who lift heavy loads, high impact activities, all this should also be mentioned. And of course, write a note on congenital syndromes like Ehlers-Danlos syndrome, which can cause nulliparous prolapse, connective tissue disorders. So this would be a complete answer for etiology. Okay, so just put this table across for anatomical factors and predisposing aggravating factors. Okay. Next question was from physiology of pregnancy. What cardiovascular hemodynamic changes take place in antenatal women near term? Okay, so what precautions would you take in a patient with rheumatic heart disease with severe MS at 32 weeks? And what is supine hypotension syndrome? So simple subdivisions. The first is the hemodynamic and cardiovascular changes. Mention about the heart rate. Okay, this is just to complete the answer. You're not supposed to write this. When I make the table, I want it to be complete. But what to mention, heart rate is important. Stroke volume increases. Cardiac output peaks around 32 weeks. The vascular resistance will go down. Mean arterial pressure will drop slightly. Venous return decreases in the supine position. That will also answer our last question, supine hypotension syndrome, and increases in the left lateral position. Plasma volume increases, red cell mass increases, but the difference, it's not an equal increase, hence there is physiological anemia because of hemodilution. Then cardiovascular changes on ECG, there's left axis deviation. And heart sounds, there's a loud S1 and S2, physiological S3, ejection systolic murmurs. These are all the cardiovascular changes. Okay, what precautions would you take in a patient with rheumatic heart disease with severe MS? So the goals are to prevent her from going into failure. How can you do that? By preventing tachycardia and preventing volume overload, right? So what will you do antenatally? Avoid physical exertion. Diet should be avoiding too much of fluids. Drugs, if she's taking beta blockers, will help in reducing the heart rate. Diuretics for heart failure, anticoagulation. If she's on, what is she on? That has to be checked. Then infection prophylaxis, rheumatic prophylaxis, then fetal surveillance, look for IUGR, preterm labor, she's at risk, cardiology workup depending on the WHO or NYHA grade she's in, positioning advisor that to be in the left lateral rather than the supine position, avoid anemia, avoid infections, avoid sudden postural changes, avoid excessive fluids, and cardiology intervention whenever if required. Then intrapartum, hospitalize her early, strict input output charting, oxygen, she should be on oxygen. Analgesia is very important. Epidural is the preferred analgesia. Second stage should be shortened by forceps vacuum. One point which I think has been mentioned, okay, it's mentioned here, avoid methergin. That's very, very important. Oxytocin is a drug of choice. Restrict fluids in the intrapartum period, and endocarditis prophylaxis if indicated. Postpartum, first 24 to 48 hours are very crucial because she can go into failure because of the sudden increase in cardiac output. Keep for observation for longer than the routine patient. continue diuretics, beta blockers if required, anticoagulation if indicated, and counsel for contraception. Avoid estrogen containing contraceptives. So your answer should be complete. Okay. What is supine hypotension syndrome? Again, here is where a diagram will help. So you can draw a diagram which shows that in supine position, the gravid uterus is compressing the aorta and the vena cava, and this compression is relieved by putting a pillow under her right hip, which will make her move to the left side. So this compression is relieved. This whole thing is called a supine hypotension syndrome. It is because of the gravid uterus compressing the IVC against the vertebral column. This leads to decreased venous return to the heart, leading to reduced cardiac output, and the patient is going to have dizziness, hypotensive episode, restlessness, and even syncope. And as a result, the fetus may have bradycardia. This usually occurs within 3 to 10 minutes of assuming the supine posture. Her blood pressure is going to drop, and the pulse rate may increase initially, but then may get depressed. How do you prevent this? I always advise the patient to be in the left lateral when you're doing a cesarean. Also, because of added hypotension of the anesthesia, she can go into profound hypotension. Always put a wedge underneath her right hip. Okay, so clinical significance is common during anesthesia. In cardiac patients, even minor venous return reduction can precipitate failure. So, you have to be very careful if she's already compromised. Okay, so must be anticipated during cesarean section and third trimester imaging. So many patients in the third trimester, when you're doing an NST or when you're doing an ultrasound, they feel very, very uncomfortable. That's because of this problem. So you should anticipate and you should make them comfortable, and you should know if a patient is feeling lightheaded while doing a scan, you should know, turn her to the left side. That's all that we have. That is important. Okay. Next question is describe the decidua. So again, a physiology question. So the first paper is all about this anatomy, physiology. So just go through all the important anatomical structures, go through the important physiology, especially placental physiology, especially pregnancy related changes, because one question is going to come from placenta, one question is going to come from other physiological related changes in pregnancy. So describe the the decidua, describe the stages of development of the trophoblast, and what do you understand by trophoblastic invasion of the spiral arteriole. So the first part defined what is decidua. Decidua is the endometrium of pregnancy, which is basically under the influence of progesterones. Okay, so under the influence of progesterones, the endometrium becomes favorable for implantation, and importantly, the types of decidua is important to describe. Draw this diagram, very easy to draw. So this is the uterus, okay, and you can draw the lining. This is the decidua, right? Now the embryo is going to implant somewhere here, and it's going to be covered by decidua. So the decidua on this side, or where near the uterus, where the future placenta is going to be, is called the decidua basalis. The opposite side of it, this decidua over the opposite side of the embryo, is the decidua capsularis. It forms a cap over the embryo. And this remaining decidua over the rest of the uterus is the decidua parietalis. So what's going to happen as this pregnancy is going to grow, the capsularis and parietalis are going to get fused. This and this will get fused, and there will be obliteration of the uterine cavity. So this is the three types of decidua. Basalis, capsularis, which fuses with the parietalis by the 4th to 5th month, and the parietalis, which is the decidua vera. So these are the three types of decidua. Draw the diagram. Also, you can write the histological classification. You have at the bottom the basal layer, which will stay, doesn't get shed off. Then the middle layer, which is the spongy layer, decidua spongiosum, which is the layer of separation of the placenta. Then you have the decidua, the stratum compactum, that is the superficial compact layer. So this is this is the histological classifications. You have two types of classification if you're asked about classification of the decidua. So you have the basalis and you have the spongiosum and the compactum. These two are called the decidua functionalis. So decidua basalis, decidua functionalis. This part gets shed off with the placenta at delivery. Okay. The stages of development of a trophoblast, this is basically your placenta, how it forms, wala question. It is important. It's something which you have to learn. It's not easy to explain in detail now, but you have a pre-implantation or formation of the trophoectoderm. Then you have early implantation, where you have division into cytotrophoblastic cells and syncytiotrophoblasts. Then you have vacuoles appearing within the syncytium. This is called the lacunar stage. Then you have the primary villi, secondary villi, tertiary villi forming, right? Then you have the final placenta forming. So this is the description of the different trophoblastic stages. So here basically you have to write formation of the placenta, the primary, secondary, tertiary villi. Okay, and that would be your answer. What do you understand by trophoblastic invasion of the spiral arteries? What happens is you have to here show this diagram. This is normal pregnancy, the tortuous spiral arteriole, which has less blood supply, and this is a normal pregnancy where the spiral arteriole has been invaded by the extravillous trophoblastic cells, and it has made the arteriole dilated and allowing more blood to happen. But in the preeclamptic lady, there is deficient invasion of the trophoblastic cells in the spiral arteriole, leading to a lot of less blood supply, and that triggers a host of inflammatory mediators leading to preeclampsia. So that's what the basic idea is. So what happens is there's shallow or incomplete trophoblastic invasion. The spiral arterioles may be remodeled partially, but myometrial segments remain smooth. These vessels remain narrow and responsive to maternal catecholamines, and this results in reduced uteroplacental hypoperfusion. This releases anti-angiogenic factors and inflammatory cytokines, which further cause endothelial dysfunction in different organs. So that's what's happening in preeclampsia. Okay. So the clinical implication is that there'll be increased uterine artery resistance, there will be increased anti-angiogenic factors, and this will serve as predictors for preeclampsia. If you write nothing but just draw this diagram, you will get, and you just mention this sentence, there is defective trophoblastic invasion of the spiral arteriole in preeclampsia. That is enough to get you your 2 marks. That's all that needs to be written. Okay.